So there's really, beyond using tocilizumab and people commonly using steroids for CRS, there's really no standard for what you use post those two therapies. If you've given multiple doses of tocilizumab and you're already on steroids, it's sort of you're using clinical judgment management and then some guidelines that have been put up, and really no evidence-based guidelines for management of severe CRS. And so we and others have published cases on using Emapalumab as a way to treat life-threatening CRS when other agents have not worked. And in small case series that has shown benefit. But the other commonly used medications that are used to treat refractory CRS include Anakinra, which there are several centers now that are trying to incorporate that a little bit earlier when it seems like tocilizumab and steroids are not having the effect desired. And I think that has promise for being beneficial, potentially earlier on in therapy, as opposed to waiting until patients get incredibly sick from CRS. Other therapies that are sometimes used include Siltuximab, which targets IL-6 directly instead of the IL-6 receptor like tocilizumab. There have also been reports on using this in CRS, and there was one actually at TCT that had talked about using Siltuximab in the management of refractory CRS. And then beyond those, the life-threatening CRS that has been unresponsive to steroids, tocilizumab, and then things like Anakinra and Siltuximab, I think that's when things like Gamifant or Emapalumab begin to be considered, because you're targeting interferon-gamma. It's been shown to be effective in primary HLH, and there's often very elevated interferon-gamma levels in patients with severe CRS, and so blocking it has rationale. And I think that is a medication that when you give it, it's there, it does have a half-life, and it's going to go away, and it shouldn't be directly toxic to the T cells, but it does impact one of the main cytokines that they use. So there's some concern that it could impact CAR T cell functionality. However, Marcella Maus, her group has found that in hematologic malignancies and preclinical models, it doesn't seem to affect the ability of CAR T cells to be effective and have effective cytotoxicity. Another agent that is sometimes considered for highly refractory cases of CRS with HLH-like manifestations includes etoposide. There's controversy about using etoposide because it could influence, or it likely will kill CAR T cells. And so there's a concern for efficacy of the CAR T cells, and really reserving this for when there are life-threatening consequences because of the cytokine release syndrome, and you really demonstrated refractoriness to other agents. And then other medications like Ruxolitinib are often considered as well. And I think, this is something that it has potential to affect the efficacy of CAR T cells, but when you're in that refractory circumstance, I think that it's reasonable to consider adding Ruxolitinib in as well as a treatment. But that being said, all of these things really require further study and looking at long-term outcomes of patients who have received these therapies when in life-threatening situations during CRS.